Hi, I'm Jenny. I'm a pharmacist currently with CT surgery, but when you guys started up, I think I'll be one of the 3 pharmacists rounding with you all.
Yay.
Yeah. And I'm glad that Carrie asked me to give this talk because I think you guys may see a lot of heart transplant, maybe. Are they gonna transfer to you guys after?
It depends on their, where they are on their pathway. If they fall off the post-transplant pathway, then I think that they'll come to our service most likely once their chest tubes are out. But if they stay on the pathway, they may go directly to the floor, to Card B. And we'll get all the readmits that need ICU care.
Okay. So I guess when you get all the readmission, mostly potentially is graft dysfunctions or rejection. So that will be a good talk. And I don't know where my slide go. Where is it?
It's right at the bottom.
Oh, here.
Yeah.
Okay. Okay. So I did make a handout for you all. If you want to keep notes or whatever. And I apologize, some of those have heart transplants, not lung transplants, so on there I forgot to take it out, but I took it out on here. And these are some review articles that may be helpful. I missed the deadline, but I printed out for you. It's just a general overview on the literature for heart transplant. So, do you want me to can I sit or?
Yeah, you can stay right where you are.
Okay, great. So heart transplant immunosuppression. So for this presentation, we'll talk a little bit about the induction and maintenance therapy for these heart transplant patients and identify how to dose these medications and what are some of the side effects and drug interactions you have to watch out for. In the end, I'm just going to talk a little bit about peri-op immunosuppression and also how do you treat rejection and how they simply diagnose them. Not to go into detail, but what kind of grading they use and all that. And the first heart transplant was done in 1967 back in South Africa. And the first one we did in the UW is 1985. And we have done about 660 some odd numbers heart transplants throughout. I think I found this number up to June 1st, but as of right today, I think we did 16 or more heart transplant, but I believe it's less than 20 so far. Do you know the exact number?
I thought that they had said that we had done 26 so far as of last week.
Oh, 26. Okay,
I
so
know we did a lot
16
over July 4th weekend.
Yeah, I think 16 is up to the June mark when they sent out the email, and then I didn't count the rest for the past couple months, but we did have like 5-6 of them come all at once the last couple of months. So the survival rate with UW is pretty good post-heart transplant compared to national. The first year is about similar. The 3 years mark is 95% survival rate. By 10-year mark is 75% compared to the national around 50-60%. So we think we did pretty good job in terms of keeping them alive after surgery. This is a graph that I got from the ISHLT registry, and just to tell you what are the leading causes of death for heart transplant. And you can see the acute rejection, graft failure is the most common one, and acute rejection and CAV is part of them, and CAV is cardiac allograft vasculopathy, and people think that chronic rejection actually is the reason why people develop CAV. So then with this being said, so we're going to talk about immunosuppression and how we have done throughout the past 20 years and what have improved our outcome with the current advance of the treatment. So this is with the good immunosuppression therapy. If you look at 2010, 2011 compared to 6-7 years ago, rejection actually has decreased from 30% to about 25% with the current use of immunosuppression, and with more data coming out and how they use their medication. And then throughout the year, people tend to go into the hospital less with the good regimens that we had provided them. Back in 1994, majority of them, by the year of 2, they would come, 50% of them would be in the hospital somehow getting some sort of rejection treatment, versus now the freedom from hospitalization of rejection is a little bit higher. So there are mechanisms of actions in terms of how do we actually suppress those T cells from proliferating and create rejections. So there are multiple different targets that we do to help with rejection. This is the antigen presenting cell, and then it presented to our T cell receptor, and then it goes through this, and then the calcium will be stimulated and influxed into the cell, and then stimulate this calcineurin, which is an enzyme, and then it phosphorylate, convert the NFAT-P to NFAT, and then this factor would go into the nucleus and then transcribe the IL-2, and the IL-2 go to the IL-2 receptor and then stimulate the cell cycle going. So there are many drugs that kind of block all these different pathways to decrease the T cell proliferations, and we'll talk about every one of them. So there are two kinds of therapy. When you talk about immunosuppression, you'll hear induction therapy and the maintenance therapy. The induction therapy is usually given very early on at transplant in the OR and continue for a few days after surgery. And the maintenance therapy is the one that the patient will go home on and to prevent rejection. So there are several benefits in induction therapy, and it is controversy whether or not we should be doing this. And some of the benefit is because the induction therapy lasts for weeks, so then you can start the calcineurin inhibitor a little bit later, and which is calcineurin inhibitor, which block this little guy here. It does create a lot of nephrotoxicity, and then if somebody have bad kidney functions, then with the induction therapy we can delay the calcineurin inhibitor to be started. And then maybe potentially you can decrease the corticosteroid. There are thought that maybe it have less rejection. Whether or not it improves survival is questionable, and there's also a thought about decrease the cardiac allograft vasculopathy too with the induction therapy. So there are some benefit out there, but there also potential harm is more risk of infections and malignancy could occur later on down the road. And then based on the ISHLT registry though, they took a survey and see what other centers do around the world. It's only like 50% of them really using induction therapy. Any induction for the primary transplant is only 50%. So 50% of the world don't use induction therapy. So you know that it's controversial whether or not this is beneficial. And then majority of them is either using BASILIXIMAB, which is an IL-2 receptor antagonist, or ATG. And these are all, this one is already out of the market, the OKT3, and elotuzumab is the data is not very strong, so we don't even use it here at the moment. So in terms of survival, whether or not there is a benefit between any agent and with induction, actually, based on the registry, there's no survival benefit really with induction therapy, but some people do believe that it could, because of these benefits, we'll still do it. In our center, we induce almost everybody, unless they have rabid antibody or their platelet is super low, like we cannot really give them this ATG. And there are a couple that we use in our hospital. But primarily for the heart transplant, we use the cytolytic polyclonal anti-thymoglobulin, which is the rabbit ATG, and the AdGam, which is the equine ATG, tends to have more, what do you call that? I forgot the term. Oh, serum sickness syndrome or cytokine release syndrome. So we don't use that anymore. But we don't use this very often. And then this one has a lot of cytokine releasing syndrome associated with that too, and it's not proven to be any better. So then it's actually withdrawn from the market. And there's another one that's called IL-2 antagonist, which bind to this receptor and block the IL-2 from acting onto the receptor, and so stop the cell cycle. It's called BASILIXIMAB. That's what we used. And daclizumab is something that we used to use, but now is also withdrawn from the market. So there's not very many that we need to know. We only have ATG and BASILIXIMAB.
Where does rabbit work on the T cell?
It just it works on multiple different antigens, CD receptor. It just binds to it. It just lights the cell and all that. So it's not specifically listed in a particular one because there's a lot of antigen CD receptor on the cell that they actually bind to. ATG also deplete B cell as well as T cell. So, now that's the mechanism of action. So it's a polyclonal antibody that bind to all these different protein membranes, like the CD2, CD3. There's a bunch other that. So then it caused by lysing the cell and prolonged T cell depletion. After you give the induction therapy, it can last up to 4 weeks, the effect. But usually you don't want to not start Tacro by day 4 or 5. You kind of want to start all the chronic medication at about 5 days and work up the level of that. And then it has a moderate cytokine release syndrome. It can cause that, which is like when you lyse a cell, all these cytokine kind of release, so you get this hypotension, Riker kind of event happening with this medication. So sometimes we'll see that, but if you slow down the infusion, it could help. And I don't see this very often in our unit, but sometimes it can happen. And the main thing is depleting the platelet. So then we sometimes don't give it if their platelet after surgery is like really low, like less than 60, and then we'll wait till the platelet kind of recovered. Then we'll give the drug again. The dosing is listed on your handout, which is for your reference. We usually pre-med them before just to prevent all those infusion-related reactions. And it can be infused over as long as 12 hours, but usually we do 6 hours. And it's very expensive. So the nurse usually will make sure that we're gonna give it before we mix it, because the bag, once it's mixed, if it's not used, then $2,000 gone. SIMULECT. So this is BASILIXIMAB. It's bind to the CD25 antigen on the IL-2 receptors, and it decreases the proliferations. And the half-life is really long, so it's lingering around in your body for a very long time. And from the package insert, it said that the drug actually was saturated on the receptor for like up to 60 days. But whether or not it provide less rejection for 60 days or prevent rejection for 60 days, I don't know. But we usually start tacrolimus around 5 to 7 days as well with this medication on board. And then it's less of those infusion-related reaction happen to this. It's very well tolerated usually. It's usually given on post-op day 0 and 4, and it doesn't usually deplete your platelet as much. So compared to those two, like BASILIXIMAB versus ATG in heart transplant, we tend to stay with ATG because ATG some people, there are studies have shown that maybe work better than BASILIXIMAB in terms of preventing rejection, but there's no survival benefit in any of these agents. So now we go through the maintenance therapy. There are usually with our patient, will be on 3 agents for sure. So it's the calcineurin inhibitor, the T cell the one that deplete the T cell productions, corticosteroids, and MTOR inhibitor, which is usually used later down the road.
So you give ATG or basiliximab?
Yeah.
One or the other?
One or the other.
Okay.
But with our center, we don't use basiliximab
Oh,
very
okay.
often, but other center do.
Okay.
So calcineurin inhibitor, basically, they bind to this little guy here, and then it decreases the transcription of the IL-2, and it's like more like upstream blockade to prevent cell proliferation that way. And we have 2 different kinds of calcineurin inhibitor, either cyclosporin or tacrolimus. And cyclosporin come in different form. So if happen your patient came in on cyclosporin, you should find out if they're on Sandamune or Neuro. Sandamune has more unpredictable absorption, and a lot of people are not on it, but we should make sure though, because their bioavailability are not the same, so we have to stick with, usually we just have to make sure we stick with the one that the patient is on. Neural is more common, and it has better oral reabsorption, more predictable level in a sense. And they're both metabolized extensively through the CYP3A4. So there's a lot of drug interaction, which I'll talk about. And tacrolimus, also called FK or Prograf, and it's more predictable compared to cyclosporin. And then we sometimes use the IV, but we hardly ever. There is a way to get patient absorb the drug without using the IV formulations. It's sublingual. And so if the patient is nauseated, like have high tooth residual and the gut is not moving, you're worried they're not absorbing, sublingual is an option, although I'm not listing it there, but like the conversion between sublingual and regular oral pill is 1:2. So 1 milligram of oral swallow equal to 0.5 of the sublingual. So they absorb better if you put it under the tongue. But the nurse need to be very well educated if you really want to do that, because you cannot mix the powder with the water. You have to open the capsule and put it under the tongue and let it sit for 20-30 minutes. So it's better for intubated patient, because they're not going to be moving the tongue around or swallow the drug right away. And it's also okay for cystic patient, because this is what they look at in the cystic fibrosis patient in UCSF. They published that sublinguals actually work, because this cystic patient usually don't absorb very well. So then we do that. But with heart transplant, I don't run into that problem very often. Cycles, these are how you monitor the level. So if they're on cyclosporin, these are the guideline from the lung transplant book for the heart transplant book that they not officially put out, but is out there. The tacrolimus usually between 10 to 15. And then this is just a general guide for you to know like how much a patient will need for tacrolimus. It's about 0.025 to 0.05 POQ12, but we usually start a little bit lower to bring them up slowly, just to make sure their kidney function tolerate. So some of the side effects with cyclosporin, there are, let's see here. Tacrolimus is thought to be better tolerated if somebody is hypertensive and with high triglyceride or cholesterol, but it does give you more high blood sugar with the tacrolimus. And cyclosporin has this problem called gingival hyperplasia and hirsutism. So it's more like cosmetic. So if patient can't tolerate it, then they can switch to tacro. But tacro and cyclosporin, they both would cause renal insufficiency, and the earlier on it's more like a vasoconstriction effect, that causes renal insufficiency, but later on down the road it could cause like interstitial type of damage too. And they will make your potassium go up. So some patients are on so much tacro that they need to be on K-oxalate every other day to bring down their potassium. Sometimes you have to add some other agent like fludrocortisone to help with bring down the potassium. So it's not uncommon. Neurotoxicity seems to be more common with tacrolimus than cyclosporin. So PRESS is something that people think about, like, and posterior, some sort of posterior something encephalopathy
syndrome.
reversible.
Yeah, reversible encephalopathic syndrome.
Yeah. So then, which is people can have seizure with it. Then, if that's the case, it's more like diagnostic of an MRI. They have to look for a specific pattern, and then, but once they stop the drug, it's not. Usually, normal level could also cause the problem. So it's not only just high level, and then usually switching to another calcineurin inhibitor would help. And then, in terms of which agent to pick. Why are they using cyclo versus tacro? Based on the guideline, tacrolimus is recommended over cyclosporins because potentially it does keep them out of rejection better than cyclosporin. So there are more patients experience rejection with the cyclosporin combo than the tacro combo. And then although they're not in terms of survival, whether or not you pick cyclo or tacro, there's no difference between the two. So the next agent I'm going to talk about is the T-cell proliferation inhibitor. Is basically stop the cycle here. It's a purine analog that incorporate into the DNA and disrupt the synthesis that way. And azathioprine is rarely used, but if patient cannot tolerate the MMF, which is I will go over next, usually would go into this agent. And IV to PO is 1 to 2 as well. And the metabolism of the drug, there are 3 different pathways. So one is the xanthine oxidase, the other one is the TPMT, and these are all inactive. And then there is this AGPBT, which is some sort of transferase, would convert the prodrug into this agent, 6-MP into this, which is 6-TGN, which is very active. And then when I talk about this pathway, you have to think about drug interactions because there's drug interactions major with allopurinol. Like all these patients may be on allopurinol for gout, and then somehow they're on isotherapine. Then you need to think about just even restart the medication because by blocking this, then they're less 6-MP go into this inactive pathway and more go into this active pathway. So then there are more active drug of azathioprine linger around, then it causes bone marrow suppression and all that. So people actually can die from it, which it happened to one of the patients. Side effect would be monitor liver.
They died from leukopenia.
Yeah, extreme leukopenia. So then if really need to put those two together, you have to decrease the azathioprine dose by a lot, like 50 to 75%.
Otherwise, you just stop the allopurinol.
Exactly. So mycophenolate is the most common anti-metabolite that we use. It's called CELLULAR, which usually when they're in the hospital we do that, and it's 1,000 milligrams twice a day, but it comes in 250, 500 milligram strength. Myfortic, we used to use this formulation a lot, but we got contracted with the manufacturer or wholesaler. We got cheaper price with the CELLULAR, and it's generic. Myfortic, usually we do that for patient that have very severe GI side effect with the MMF, which is the most common side effect with the medication. And people can actually get colitis with this med because of the direct injury of the metabolite into this gut. So then potentially switching will be helpful. And then there are levels that we talk about that you can draw in the unit. Let's say you're suspecting toxicity, then you can draw an MPA level to see if the patient is having too much mycophenolate in the body. But usually the range itself is not correlated with outcome in terms of, oh, higher level is better than no level at all. That is not proven to be the case. So if there's no toxicity or rejection, let's say somebody is rejected, then you want to keep their level a little bit up. But otherwise, you don't normally, it's not like a routine thing that you check for drug level. Common side effect, again, is nausea, vomiting, diarrhea is very common. So you can either switch it to the enteric-coated myfortic, or you can divide the CellCept dose into multiple, like a smaller dose, but multiple times a day. So they may help with the diarrhea a little bit. Sometimes give it with food or lower the dose, but we generally try not to reduce the dose because we don't want them to get insufficient immunosuppression.
So which way of checking the serum levels do you do here?
We do this one. Oops. The MPA.
Okay.
Yeah, we don't do the AUC. IV and PO is pretty good absorption. So IV to PO are 1-to-1 conversion. And it is a prodrug. It go into MPA, which is active, and then it will glucuronidate. This is inactive. And then the inactive product, because majority of the inactive product is eliminated through the kidney, and 6% are eliminated through the biliary system. So once it's in the gut, it got reabsorbed again, so you have more drug again in your body. So we call it enterohepatic recycling. So you may see too little peak in terms of absorption because it got recycled back again. And that recycle back of the MMF also can be affected by some other drug too, like cyclosporin, which inhibits some of those pathway and decrease the drug level, MMF drug level that way. So there are cyclosporin, so you may need a higher MMF level because it blocked the hepatic recycling, so less drug being absorbed. And if you're doing all this product, it may interrupt the absorption as well. And corticosteroid, you all know what steroid is, so but it inhibits here IL-2 gene, also IL-6, TNF, and interferon. And then the overall is to decrease activation and proliferation of the T cell. And there are multiple different kinds of corticosteroid. There's methylprednisolone, which we use post-op, and then for a few doses, and then we'll convert them to prednisolone. For maintenance therapy, their biological half-life is longer than their serum half-life, so the effect, even though they miss a dose, the effect still linger around. And in terms of what they get in the OR, they got 500 milligrams of the methylpred all at once in the OR. So usually they're very hyperglycemic post-op, particularly with that. And then after that, you're on 125 IV BID for 3 doses, and then taper it down to 0.15 milligram per kilo per dose twice daily. So then, so it's based on actual body weight, not ideal body weight. So if your patient weighs 100 kilos, then he will be 15 milligrams twice a day. And then they do biopsy every week for the first couple months, and then they will do every other weeks after that. And then depends on the biopsy. Then after the 2 months point, then they start coming down on the steroid as well. And some of the side effects are listed here, like you may know it will increase your blood sugar, make people a little bit moody, and which a lot of these patients tends to be on some sort of insulin to go home when they're on high dose steroid. More with the lung transplant than the heart transplant, I would have to say, because lung transplant get a lot higher doses of steroid post-op. mTOR inhibitor is basically that block over here. There is this enzyme called mammalian of the rapamycin target. So it's an enzyme that actually needed to go through this cycle. So it binds to the FKBP12 and form a complex that inhibit this toll, and cell cycle stop. And this agent we use, there are two, they're called SIROLIMUS and everolimus. And usually they try to use this medication because then with the combination of, it sounds similar to tacrolimus, they're completely a different entity. And they may use SIROLIMUS with tacrolimus. You'll see your patient come in it after like several months of transplant, the kidney function is not recovering. They may transition him onto this SIROLIMUS tacro combo, so less tacro. So the goal of tacrolimus can be brought down. Instead of like the 10-15, when you added this medication, you can brought down the level to like maybe 6 to 8, depending on what they want. The attending usually drive that goal, like what the level they want. But with addition of SIROLIMUS onto the tacrolimus, you can potentially bring down the level of tacro and cause less nephrotoxicity that way. And then it's also thought that can be prevent or help with the coronary allograft vasculopathy as well. Let's see. So the other level, and somebody is coming in with cyclosporin and sirolimus. There is a major drug interaction, so that they have to space at least 4 hours apart. They cannot be given together because then it will increase the sirolimus level while long, but not with the tacrolimus. And it has a super long half-life. So then you only dose it once a day as well. Some of the side effects, patient potentially, with sirolimus or any sort of everolimus, they can cause wound healing problems. So and then they thought that maybe, I think they did a study to look at whether or not we can drop the tacrolimus, just put people on sirolimus and MMF, and they tend to have more rejection that way. So we definitely need to have calcineurin inhibitor on board. But everolimus also everolimus, which is another mTOR inhibitor, potentially can cause more pleural effusion with this pericardial effusion. And so post-operatively, a lot of them don't like to use this medication because of the side effect that it could cause. And usually it's down the road chronically, and then they start thinking about rejection, CAV, and all that, renal function, then they will switch patient over. There are just a couple charts on your handout talk about like drug interactions, which you can take a look, and most of them you have to think about drug interaction is inhibitor. So any fluconazole, any sort of fungal, azole, macrolide like clarithromycin or erythromycin will increase all this level for the immunosuppression. And then any drug like rifampin, phenobarbital, isoniazid, all those medication down the bottom is like, we call it inducer. So induce your enzyme in your liver and then increase the metabolism a lot faster. So just think about drug interaction whenever somebody is on these agents, because there are a lot. And not just medication, like people on herbal supplement and food, grapefruit juice and all that could also cause issue with the drug level as well. And these is just because it's potassium retaining, so you have to watch out for that. And I talk about the cyclosporin already. So this is just general thing with the pre-op heart transplant, what they get in the OR. They got the mycophenolate, ATG, and methylpred in the OR for immunosuppression. And then post-operatively, they all gonna be on mycophenolate 1 gram twice a day, IV or PO, methylpred for 3 doses. These are all on the power plan, so I just take a screenshot of it. And then this is the prednisone start after the 3 doses of the methylprednisone. And then ATG is 4 doses total, so 1 in the OR and then 1 milligram per kilo post-op day 1, 3, and 5. So they all gonna be getting 4 doses of ATG. If their platelet is less than 50,000, then they have to call the attending and see if they hold it. There's another team called MCS team. They also come and make recommendation if the ATG need to be given or not. So to confuse you guys, and then this tacrolimus, then we usually start post-op day 2 if their kidney function is good. To just briefly mention, these are the standard. There are times that we will completely don't give them inductions, then they remove them to the non-induction protocol. What it means then, the oral immunosuppression will need to be cranked up. So the mycophenolate no longer 1,000 twice a day, will be 1,500 twice a day. And the steroid no longer is 0.15 twice a day, will be 1 milligram per kilo. Is that 1 milligram per kilo? I believe it's twice a day.
And it goes on for longer before the oral starts, doesn't it?
Yeah, so no.
Does it taper before
Actually,
the
it's
oral?
1 milligram per kilo a day, and they divide it into 2 doses. Let's say it's 100 kilo, then will be 50 BID. And then every day they go down by 5 milligram per day until they hit 20 BID. And then they stay on 20 for a while. So it's a lot higher than what a person who get ATG. And then the tacrolimus almost start instantly, and they want to crank up the tacro as much as possible. Can get to the level of 10 to 15 as soon as possible. So those are something that may happen if somebody, or you may see from post-op that, oh, why are they not on ATG, on some weird funky dose of immunosuppression, that may be a reason. So just a few more slides on rejection. So which potentially you will see from readmission. There are different types of rejections that they classify. There's a hyperacute rejection, acute rejections, and also a chronic rejections. Hyperacute rejections that happen very quickly after surgery, it can be minutes, hours. That's usually antibody driven, so it's like more humoral type of rejection. So that, and then for acute, it can happen months after transplant. It can be a cellular rejection or antibody-mediated rejection, or humoral rejection, also called B-cell rejection. And then chronic is more like a long-term type of rejection, like chronically, but not like slowly, but long. And usually it's associated with more like cardiac allograft vasculopathy. It could happen months, years down the road. And the only way to diagnose them, which is gold standard, is the endomyocardial biopsy for both rejection. And for the acute cellular rejection, there are different grading systems. The old kind, which some attendings still use, they have 0, 1, A, and B. And depending on what they see in the biopsy, they grade them 1A, 1B, or 2. And then more severe one is grade 3. It could be focal or diffuse, and grade 4 is very severe. So you will hear this, and then you may also hear this standard grading system too, called 0, 1R, 2R, and 3R, which is no rejection, mild, moderate, and severe. You may see both in interchangeably, but usually we don't treat mild rejections, then they just observe and just do more biopsy and see how they progress. Some people start worried about 1B, 1A definitely, they just kind of observe and monitor. 1B, maybe grade 2, they usually treat grade 2 and on. And the treatment for acute cellular rejection, this is extracted from the ISHLT guideline back in 2010. We do use, it's a T-cell rejection, so we do use corticosteroid or ATG. We don't use the OKT3 anymore, we don't use this, so basically just this and steroid pulse. In terms of antibody-mediated rejection, there are a couple way or factors that people look at. They look at their function first, and so by echocardiogram, see if they're functionally, are they still good? Is the heart still good? So with the biopsy, they also look at histologically and see what kind of infiltrate they see in the biopsy. Immunologically, they also send off a bunch of labs to see if there's a DSA, donor-specific antibody, and see if there is any positive. They do retrospect cross-match post-transplant, and then if they are rejected, and see if there's anything light up as positive. So after looking at that, then once the diagnosis is confirmed, there are things that we can do to treat acute, antibody-mediated rejections. We can use steroid first, and then plasmapheresis is another one we will do. And after plasmapheresis, we will do IVIG. If there's severe rejection, they will potentially give them rituximab also. So this is just general rejection, kind of typical things. Thank you. Yeah, I don't have any questions.
In what patients would we not use induction therapy?
In what patients?
In which patients do we just not, do they not be
So
considered?
the one that I see most commonly we don't do is the one with rabbit antibody.
Okay.
I don't know why they check it.
They don't anymore. I
So,
checked yesterday.
They don't check it anymore. Yeah,
Yeah.
they used to check it and no one look at it, and then somehow somebody start looking at it, and then they're like, oh, we can't give them NTG because they're rabbit antibody. But it doesn't really tell us anything in terms of what does that mean, like does that mean that the drug worked less? I have no idea. Or the patient is gonna crumps, I don't know. So that was the time we don't use induction. There's also time that if somebody completely fresh transplant have zero risk factor, let's say they're not African American, they're not, they don't have an LVAD, or they have like no PRA, then maybe the attending would say this person isn't good, or they have really low platelet. Yeah, but majority of them we try to induce them, especially we do so much fat patient, and then they are at higher risk of developing rejection. So, and because they got all these transfusions and all that stuff, it's very bad procedures. Yeah.
Thank you so much. That was wonderful.
Thank you.
Thank you.